Welcome back to the deep dive. Today, we're jumping into something really important, especially for anyone looking after kids in a medical setting: managing pain and using sedation safely during procedures.
Yeah, it's definitely a critical area. Balancing comfort and safety. It takes real skill and understanding. Get it right, and it makes a world of difference for the child.
Absolutely. So we're diving into a detailed medical chapter covering procedural sedation and analgesia PSA. They call it specifically for kids. Our goal here is to pull out the essential takeaways, the core ideas, the safety stuff, the techniques, basically how to keep young patients comfortable and safe based on what this text says.
Okay, sounds good. We'll start with the basics. The source talks about sedation as more of a continuum, not just one thing.
A spectrum, sort of?
Exactly. It ranges from just minimal sedation, maybe just easing a bit of anxiety, all the way through moderate, deep sedation, and then, general anesthesia at the far end. The big difference is how much the patient can maintain their own airway and respond.
Right. And the source breaks down some terms, too, like anxiolysis, that's just reducing worry.
Pretty much. And analgesia is specifically about pain relief without necessarily changing their mental state on purpose.
Okay. Then there's dissociation. That sounds different.
It is. Think ketamine. It puts the patient in a kind of trance-like state. They get really good pain relief, amnesia too, and this is important, they usually keep their protective airway reflexes, like coughing, gagging.
Okay, so that's a key distinction from deeper sedation levels. So where does this procedural sedation and analgesia PSA actually fit?
PSA is kind of that middle ground. You're using sedatives, maybe dissociatives, often with a painkiller, so the patient can get through an uncomfortable procedure. But critically, they're doing it while maintaining their own breathing and heart function spontaneously.
Without needing like a breathing tube?
Ideally, yes. The whole point is to manage the anxiety, the pain, the whole stressful experience, but keep that level of consciousness controlled and safe.
Sounds like walking a tightrope sometimes. So, safety first. What are the absolute must-haves for doing PSA safely?
Well, first off, provider preparedness. The source really hammers this home. You need the skills, especially airway management skills, just in case things go deeper than you plan.
Right, you need to be ready for anything. And equipment.
Crucial. The text uses this handy checklist, SOPME, stands for suction, oxygen, airway gear, pharmacy, meaning the drugs and reversal agents, monitors, and other specific equipment needed. You check all that before you start.
Makes sense, like a pre-flight check. And then during the procedure, monitoring.
Oh, absolutely non-negotiable. The recommendation is actually to have a dedicated person, usually a nurse, just focus on monitoring and documenting. You're watching depth of sedation, heart rate, blood pressure, oxygen saturation. Yeah, constantly.
And I remember reading something interesting. They say while scales exist, just watching the patient is actually more reliable.
Exactly that. Your eyes on the patient, their breathing pattern, their color, how they respond or don't respond. That's your best monitor. Technology helps, but clinical observation is king.
Okay. And technology-wise, they mentioned capnography. Why is that one specifically recommended?
Right. Capnography measures the CO2 in their exhaled breath. The key thing is it can pick up on hypoventilation, meaning they're not breathing effectively before their oxygen saturation drops on the pulse oximeter.
Especially if they're getting extra oxygen.
Precisely. The pulse ox can look okay for a bit longer if they have supplemental O2, even if they aren't breathing well. Capnography gives you that earlier warning about ventilation problems.
Good point. What about other monitors like BIS, brainwave stuff?
Yeah, bispectral index. The source is pretty clear here. For kids in the ED getting PSA, it's not recommended. It was developed more for adult brain patterns in the OR, and it hasn't really panned out for reliably telling different sedation levels apart in this specific pediatric setting.
So stick to the basics. Clinical signs, pulse ox, capnography.
That's the advice.
Are there specific times during or after the procedure that are like higher risk?
Yes. The source points out two main danger zones. First is about 5 to 20 minutes after the last dose of medication, when the drug effect is peaking. The second, maybe less obvious, is after the procedure's done.
After? Why then?
Because the painful stimulus is gone. Sometimes that pain actually helps keep their breathing drive up. Take away the pain, they're still sedated, and their breathing might slow down more. So you have to keep monitoring closely until they're really back to baseline.
Okay, let's shift gears slightly. Fasting, the whole nothing to eat or drink before a procedure rule. What does the source say about that for kids in the ED needing PSA?
This is actually pretty surprising to me. Based on the evidence cited, including ACP policy, the source says routine fasting is not necessarily supported for these patients. Studies haven't clearly shown it reduces the risk of vomiting or aspiration during ED procedural sedation.
Wow, that really goes against the grain of what many of us were taught.
It does. And the thinking seems to be that those strict fasting rules often come from general anesthesia guidelines, where you're manipulating the airway routinely. With PSA, the goal is to maintain spontaneous breathing, so the risk calculation is a bit different.
Interesting. And supplemental oxygen, always have it on.
Have it ready, definitely. But the advice is not to just put it on everyone routinely. Same reason as with capnography. Really, it can mask a breathing problem, delay you recognizing hyperventilation because the pulse ox looks okay.
Okay, availability, but not automatic use.
Got it.
Let's talk about the actual medications. What are the main players?
Well, the choice always depends on the kid and the procedure. But a key principle the source emphasizes is slow IV titration whenever you can. Give the drug slowly, watch the effect, give just enough. It really lowers the risk of giving too much too quickly.
Right, titration is key. Let's dive into ketamine first. It sounds pretty unique.
It really is. It's called a dissociative anesthetic. So it gives you sedation, makes them forget amnesia, and provides strong pain relief analgesia all at once.
And what are the big advantages for PSA?
The text highlights that it generally keeps the heart and breathing stable, causes very little respiratory depression, and this is a big one. It preserves those protective airway reflexes we talked about earlier.
The coughing and gagging.
Exactly. Plus, it can actually relax the airways, bronchodilation. That makes it the go-to sedative, according to the source, for kids having a severe asthma attack who also need a procedure.
Are there downsides? Risks?
Well, rarely you can see apnea, especially if it's given too fast or in really high doses or with other sedatives. Laryngospasm, spasm of the voice box, is also rare, usually doesn't last long, and often just needs simple things like repositioning the head or giving oxygen.
How's it usually given? FI?
FIs is preferred, yeah, because you can titrate it carefully. You can give it IM in the muscle if you can't get an IV. But the source mentions more vomiting and longer recovery times with IM. Oral isn't used much for PSA, less predictable, lasts longer.
Okay. Now, there was this historical concern about ketamine and head injuries. Something about increasing pressure in the brain, ICP.
Yes. This is a really important update in the source material. For years, people worried about using ketamine in head trauma because of potential ICP increases. But the source cites newer research, including a meta-analysis, showing that ketamine does not actually increase ICP.
Seriously, so it can be used?
Yes. The evidence now suggests it can be used safely in patients with head trauma. That's a pretty significant shift in thinking for a lot of clinicians.
Definitely a major takeaway. Okay, what about propofol?
Propofol is another big one. Its main attraction is it works really fast and wears off really fast. Great for short procedures. Plus, it actually helps prevent nausea and vomiting. It's antiemetic.
And the main things to watch out for?
The big ones are potential for low blood pressure, hypotension, and respiratory depression. Because of those risks, some used to feel it was only safe in the operating room. But the source mentions a large study showing that with the right setup, good monitoring, skilled providers ready for problems. Propofol can be used safely and effectively outside the OR, including in the emergency department.
So, another case where practice is evolving based on evidence. What about mixing them? Ketamine and propofol, ketofol.
Yeah, ketofol. The idea behind it is maybe you can use low doses of each drug and kind of balance out the side effects, like propofol's drop in blood pressure might be offset by ketamine's tendency to support it.
Makes sense theoretically. Does it work out that way?
Well, according to the studies mentioned in this source, it's not quite that clear-cut. They haven't consistently shown fewer airway problems or less respiratory depression with ketofol compared to just using ketamine or propofol alone. So it's used, but maybe the benefits aren't as proven as the theory suggests.
Interesting. Okay, that covers the sedation side pretty well, but PSA often goes hand in hand with pain. How does the source talk about managing pain itself in kids?
Right. It defines pain pretty straightforwardly, that unpleasant feeling linked to tissue damage, whether it's real or just potential. And yeah, you often need to treat pain right alongside the need for sedation.
Assessing pain in kids, though, that can be tough, can't it?
It absolutely can be. The source stresses that if the child can tell you, their self-report is the gold standard. You use age-appropriate tools, like the FACES pain scale for younger kids or a number scale for older ones.
And for babies or nonverbal kids.
Then you have to rely on behavioral scales, watching their cries, facial expressions, body movements, things like the FLACC scale. And input from parents or caregivers who know the child well is incredibly valuable, especially for kids with neurological issues.
Makes sense. Now, beyond pills or shots, the source talks about non-medication ways to manage pain.
Yes, nonpharmacologic techniques. And they're really important used with medications for significant pain, not usually instead of them, but they can make a huge difference.
Like what kind of things?
All sorts. Distraction's a big one.
Yeah.
Simple like telling stories, playing games. The source even mentions kaleidoscopes.
Kaleidoscopes, okay.
Yeah, or higher tech things like video games or even virtual reality are being used now. Having child life specialists involved is fantastic if you have access to them. And just the presence of a parent can be really calming.
Any specific tricks for infants?
Definitely. Things like giving a pacifier, non-nutritive sucking, breastfeeding if possible, skin-to-skin contact. And for babies under 3 months, giving a little bit of sucrose water, sugar water, right before a quick painful thing like a heel stick can actually help.
Wow, simple but effective. Okay, let's move to the medicines for pain. Local anesthetics seem like a cornerstone.
They are. Things like lidocaine. They work right where you put them, blocking the nerve signals. Often they're mixed with epinephrine.
Why add epi?
Epinephrine constricts blood vessels locally. That does two things. It keeps the anesthetic in the area longer, so it works for more time, and it reduces bleeding at the site, which is helpful for things like stitching cuts.
But there's a big warning about where not to use epi, right?
Yes, absolutely critical. You avoid epinephrine in areas that have what's called an end arterial supply, basically, places where there isn't a backup blood supply if the main vessel clamps down.
Yeah.
Fingers, toes, the tip of the nose, earlobes. Using epi there could potentially cut off blood flow and cause tissue damage. Also cautious in patients with circulation problems.
Got it. And allergies. People sometimes say they're allergic to Novocaine or whatever.
Right. The source points out that most often what people think is an allergy is actually that vasoconstrictor reaction if some epi gets into the bloodstream.
Yeah.
They feel jittery, heart races, anxious. True allergies to the common amide locals like lidocaine are actually very rare. More often, it might be a reaction to a preservative in the vial.
Okay. But local anesthetics can be dangerous if too much is given. Toxicity.
Yes, and this is super important. Local anesthetic systemic toxicity, or AST.
Yeah.
It affects the brain for subtle signs like numbness or tingling around the lips, a metallic taste, maybe ringing in the ears. That can progress fast to seizures or even coma.
And the heart.
Yes. It can also hit the cardiovascular system, causing serious heart rhythm problems, low blood pressure, even cardiac arrest. The absolute key is prevention. Calculate the maximum safe dose based on the child's actual weight in kilograms and do not exceed it.
How about making the injection itself hurt less? Any tips?
Yeah, the source lists several good ones. Put a topical numbing cream on first if you can. Use the smallest needle possible. Warm the anesthetic solution slightly or buffer it with bicarbonate. Inject slowly. If there's a wound, inject into the tissue just under the skin or through the wound edge itself rather than intact skin. Try to minimize the number of pokes.
Okay. That leads nicely into topical anesthetics, the creams and gels.
Right. Things like EMLA or LMX for intact skin or LET for open cuts. They're great for numbing the skin before IV starts, blood draws, or minor suturing. Painless to put on, don't distort the tissue. The source does warn against using TAC, an older one with cocaine in it, due to toxicity risks.
Any risks with the common topicals?
Well, EMLA contains prilocaine, which carries a small risk of causing methemoglobinemia, a problem with oxygen carrying in the blood, especially in infants or those with certain enzyme deficiencies. But there's a much bigger warning in the source.
Uh-oh. What's that?
It's about using topical anesthetics, especially things containing benzocaine or lidocaine, often found over the counter on mucous membranes, so inside the mouth or throat.
Why is that so dangerous?
Because absorption through mucous membranes is much faster and less predictable than through intact skin. There have been reports of serious adverse events in infants and young children using these products, particularly for things like teething pain or mouth sores. We're talking seizures, breathing problems, heart issues, even death.
Wow. So like those over-the-counter teething gels.
Exactly. The FDA has actually issued warnings and recommends against using OTC topical anesthetics for teething because of these risks.
So what should parents do for teething pain?
The source suggests safer alternatives. A chilled, not frozen teething ring, gently massaging the gums, or if needed and appropriate for the child's age, giving acetaminophen or ibuprofen. This warning about mucosal use is a really, really critical safety point.
Absolutely. Okay, moving up a level from local infiltration, nerve blocks.
Yeah, nerve blocks are where you inject the local anesthetic near a specific nerve or a bundle of nerves, a plexus, to numb up a whole region. Think numbing an entire arm for setting a fracture, or a larger area for repairing a big cut.
What's the main benefit there?
The big advantage highlighted is that you can achieve profound numbness over a large area using a much smaller total amount of local anesthetic compared to just injecting it everywhere throughout the tissues. This significantly lowers the risk of that systemic toxicity we talked about.
Makes sense, and technology helps here too.
Yes, using ultrasound to guide the needle for nerve blocks is becoming much more common, even in the ED. It helps see the nerve and surrounding structures, making the block potentially safer and more effective, though the source notes may be less specific to pediatric ED research compared to adults.
Any risks with blocks?
Potential complications include hitting a blood vessel, nerve injury, infection, bleeding, though these are less common, especially with ultrasound. Again, knowing your anatomy and calculating that max dose based on actual body weight is crucial.
Okay, last category. Systemic pain relievers. Let's start with non-opioids.
Right. Acetaminophen Tylenol, good for mild pain, fever reducer, often used in combination. Generally safe liver-wise at the right doses if there aren't risk factors. Then you have NSAIDs, non-steroidal anti-inflammatory drugs like ibuprofen.
Motrin or Advil.
Exactly. Ibuprofen is often preferred in kids. Might have fewer side effects than some others. NSAIDs are particularly good if there's inflammation involved with the pain. Side effects like stomach upset or kidney issues are more likely with long-term use. And the source is very clear. No aspirin for kids because of the Rey syndrome risk.
Got it. No aspirin. Okay then. Opioids.
Right. Morphine, fentanyl, others. They work by binding to opioid receptors in the brain and spinal cord. The main thing you worry about is respiratory depression, slowing down breathing, which is dose-dependent and gets worse if you combine them with sedatives.
Other side effects.
Yeah, nausea, vomiting, constipation, itching are common. The source also specifically advises against giving opioids via IM injection. It hurts, and absorption can be erratic. And it cautions against using codeine because many people don't metabolize it effectively, and meperidine due to risk of toxic byproducts.
The source also mentioned a bigger picture issue with opioids.
It did. It touches on the significant increase in opioid prescribing over the past couple of decades and the really serious public health consequences: addiction, abuse, overdose deaths. It even mentions a statistic about the U.S. consuming a huge chunk of the world's opioid supply.
So, given that context, what's the recommendation for using opioids in kids for acute pain based on this text?
The advice is pretty clear. Reserve opioids for more severe pain, or pain that hasn't responded to other things like acetaminophen or NSAIDs. When you do use them, use the lowest effective dose for the shortest possible time. They even suggest maybe limiting it to around a week for acute issues, and you should consider the patient's potential risk for misuse.
Are there any non-opioid alternatives mentioned for tougher acute pain?
Yes, the source brings up low-dose ketamine again. Used at doses lower than what you'd use for full procedural sedation, it can be an effective option for managing acute pain.
Interesting. Okay, one last thing on meds. Reversal agents.
Right. Naloxone Narcan reverses opioids. Flumazenil reverses benzodiazepines, like midazolam. But there's a big warning with flumazenil. Don't use it if the patient takes benzodiazepines regularly, like for seizures or anxiety, because it can trigger dangerous withdrawal seizures. It's really meant for reversing an acute overdose, or sometimes after PSA if needed.
Okay, we've covered a ton of ground sedation levels, monitoring specific drugs, pain assessment, non-drug methods, locals, systemics. Why is mastering all this so vital when caring for kids?
Because undertreating pain and anxiety, what the source calls oligoanesthesia, has real negative consequences. It's not just about being uncomfortable in the moment.
What kind of consequences?
The text mentions things like poor outcomes from the procedure itself, and increased risk that the child could develop chronic pain problems down the road, and even harmful physical effects from the stress hormone changes, effects on the immune system.
So it has long-term implications.
Absolutely. And getting it right. Managing pain and anxiety well, it leads to better patient and family satisfaction, better procedural success. Plus, regulatory bodies and quality organizations are increasingly focused on adequate pain management as a measure of good care.
So it really comes down to providing the best, safest, and most compassionate care possible during what can be a really scary time for a child and their family.
Exactly. It's that blend of science, knowing the drugs, the physiology, and the art of careful, patient-centered care.
Well, this has been incredibly informative, really pulling out the key messages from this source on pediatric PSA and pain management. Thanks so much for walking us through it.
My pleasure. It's definitely a topic worth diving deep into, especially with some of those important updates and warnings.
And for you, our listener, here's something to chew on. We've talked a lot about the careful balance needed relieving pain and anxiety versus maintaining safety during PSA, especially in kids. Thinking about that, how might the growing understanding and use of non-drug methods, local anesthetics, and regional nerve blocks change how we approach pain management? Could these offer ways to provide really effective relief while maybe lessening our reliance on systemic drugs, particularly opioids?
Definitely something to think about.
Until next time, keep digging deeper.